Hi, my name is Lacey Ross, and I am doing my case study on intravenous drug use and endocarditis. So some objectives for my presentation is the student will be able to complete the following objectives at the taxonomic level listed with a minimum of 80% accuracy. So level 1 lists general clinical manifestations of sepsis and endocarditis. Level 2, describe the principles and procedures of the PathoDX for the identification of Staph aureus. And Level 3, differentiate between common pathogens responsible for causing endocarditis based on their biochemical reactions. So a little bit of background on the patient. She is a 36-year-old female, intravenous drug user, uses heroin, crack cocaine. She suffers from bipolar disorder, seizures, anxiety, depression, and she presented to Pennsylvania Hospital with altered mental status, found to be septic, with cavitary pneumonia, and also undergoing workup for possible valvular vegetation, which is a massive platelets, fibrin, bacteria, which is typically seen in endocarditis. And she did require intubation. So some more of her past history, she does have Hep C. She is known to use heroin and cocaine, has endocarditis in the past, sepsis in the past. And then on a more recent visit on February 16th, she came to the ER with head and neck pain, 2 trip and falls, and denied any kind of numbness, tingling, weakness, and denied missing her seizure medication. The patient was admitted on March 8th, and she, of course, we already know she has the known history of intravenous drug use. She had 3 days of worsening myalgias, neck pain, and chest pain, localized to the left side of her chest. She used heroin 12 hours ago before admission, and she arrived tearful, crying, agitated. She had wounds from self-injection, and she was intubated because her oxygen saturation was below 92%. The physician, the infectious disease physician, had some idea, thinking upper lobe cavitary lesion could point to aspiration pneumonia. Cavitation is a formation of a cavity, such as in the lung, like in tuberculosis, or with development of a bacterial abscess. Septic embolus due to staphylococci, now with cavitation. Oral flora in the Haysick group, which is highly aggressive and necrotizing, and the Haysick group accounts for about 5 to 10% of community-acquired native valve endocarditis cases in patients who do not use intravenous drugs. So I don't think we would be leaning towards Haysick. And then also tuberculosis. So with microbiology testing, we had several blood cultures for her, and they grew multiple bacteria. So basically with gram-positive cocci in singles, pairs, clusters, or tetrads, we're going to have the blood culture bottle, and then after the bacteria is grown, we're going to sub it onto a blood, chocolate, McConkey, CNA plate, and then we would go and do a Pasterex from there to determine if it was a positive for growth, and then from there we could report it as staph. So that's just one branch. One way you could go with the microbiology testing. If you have gram-positive cocci in pairs and chains, you would set up a strep spin, determine if you see beta hemolysis, and then from there do a PathoDX. So I'm going to get more into that PathoDX and Pasterex a little bit later. And so we did find that her blood cultures grew MRSA, staph epi, strep pyogenes, and unspecified pneumonia. So with the microbiology testing, with the manual Pasteurx, also known as Staphylococcus, it is for identification of Staph aureus. So it tests for bound coagulase. Latex particles are sensitized with fibrinogen, and they are mixed with the organism, and then clumping factor converts the soluble fibrinogen to the insoluble fibrin and causes the clumping of latex. So if it's positive, you're going to see the agglutination. And then it's also just important to note that a percentage of Staph aureus, and it's mainly MRSA strains, can elude detection in some agglutination tests because the cell wall antigens, the clumping factor and protein A, are masked. So, all right. Our next test is the PathoDX. It's for beta strep of Lancefield groups A, B, C, F, and G. So principles is the strep group antigen is extracted at room temperature and agglutinates with latex particles coated with strep group antibody. So our blood cultures show that there was group A strep, and I know the picture at the bottom actually, it shows agglutination for B, but if it were positive for A, it would just show agglutination in just the A well, and all the other wells would be negative. And that's if another well were agglutinating, that would actually mean it's inconclusive result, because if it should occur with more than one latex reagent, the problem can be three things. So it could be that you didn't take a sample from a pure colony, you had a weak reaction due to a non-specific reaction, or more than one group antigen was present in the colony. So next I looked at the chemistry results, specifically creatine kinase. Upon admission on March 8th, she had very high levels. She had 682 units per liter, whereas the average level among cocaine users is 931, so very similar. And then the average among a control group would be around, a normal population would be 242 units per liter. And then I did notice she was being treated, getting better, and then her values were actually really low, on the low end. So went from being really high to really low. And that's actually due to her hepatitis C virus, and that's seen often. She has a hepatitis C virus viral load of 321,000 international units per milliliter. Just as some background, she did show rhabdomyolysis, which is breakdown of muscle fiber contents circulating the blood. And then in this case, I would, you could also, so a lot of staphylococcal endocarditis is can be suspected in severe cases of rhabdomyolysis with acute infectious symptoms. So you would see that here. And then in the lab, they do the Roche sandwich immunoassay. I didn't actually have my chemistry rotation, so I'm a little bit rusty on this subject, but just as an FYI. So during this patient's hospital stay from March 8th through April 20th, she had a very long problem list. So we did have sepsis due to group A strep, acute and subacute infective endocarditis, severe sepsis with septic shock, heroin abuse, MRSA, and endocarditis of the tricuspid valve. So when looking at the clinical manifestations of sepsis, you can see that our patient had a lot in common, and even a lot more that were in her chart. So she had on the cardiac side, she had tachycardia. She did have cold and clammy skin, myalgia, abscess, abdominal pain, leukocytosis or leukopenia, abnormal results on her liver functioning, headache. She came in with a headache, altered mental status, hypoxia, and pleuritic chest pain. So with endocarditis, we can see that the bacterial source most likely was from an infected needle through IV drug use for her, or the open wound that was created probably by the infected needle. She did have a wound that they were taking care of as well, and I believe it was on her neck. And I did see in the history that she did previously inject in her neck, so I don't know if that's related. But with that, a lot of the bacteria we see with that is Staph aureus is 31%, viridans group strep is 17%, Enterococci is 11%, and then coag neg staph is 11%. So with that, the bacteria enters the bloodstream and it goes to the heart and forms a biofilm, and then that creates the endocarditis. So endocarditis really is an inflammation of the endocardium. It's the inner lining of the heart and heart valves. It can be caused by a variety of disease states, but the majority of endocarditis is caused by streptococci and staphylococci, as well as Candida, and it produces those biofilms that create a barrier that protects them from the bacteria from exposure to circulating antibiotics. So it's pretty bad. And then I have a little table here that has the common pathogens seen in endocarditis and their appearance and how they are differentiated. So this patient's final diagnoses are severe sepsis with acute organ dysfunction, acute bacterial endocarditis, opiate abuse, which is continuous, unfortunately, multifocal pneumonia, and cavitary pneumonia. And she was discharged April 20th of this month. So the patient was treated for their severe sepsis and acute bacterial endocarditis. The blood culture that grew step epi on multiple days had been clear since March 13th and was initially treated with cefoxitamine, vancomycin, and clindamycin. By 3/17, the blood culture started showing that there was no growth at 5 days. Continued with vancomycin, cefepime, and metronidazole. And the physician requested a vancomycin trough of about 15. The total CK levels were low, but closer to the reference range from when they were high, eventually transitioned to dapto monotherapy as per infectious disease to complete a 6-week course ending 4/21 with weekly monitoring of these. So just an FYI, endocarditis is treated with bactericidal, not bacteriostatic antibiotics. Clindamycin is bacteriostatic and useful for group A strep, so that's why she was given the clindamycin. But they do not work on the staph because they will not penetrate the biofilms that the staph creates. So to conclude, the patient developed recurrent sepsis and endocarditis from their intravenous drug usage and from bacteria from pathogens typically found in the mouth, skin, and environment. Intravenous drug users also have, which is interesting, higher rates of colonization of the skin and nose with Staph aureus than the general population. Staph aureus is the most relevant bacterial pathogen in this population, and it is the main cause of soft tissue infections, endocarditis, and bacteremia. Staph aureus is the most common cause of intravenous drug use infective endocarditis, accounting for more than half of all the cases. So streptococci and enterococci are the next most common pathogens. And in the U.S., the rate of infective endocarditis in drug users has increased with the use of heroin. So my questions, number 1, is endocarditis treated with bactericidal or bacteriostatic antibiotics? Why was clindamycin prescribed? And 2, if a patho-DX shows agglutination in more than one test well, example in A and F, are the results valid? Why or why not? And here are my references, and thank you for listening.